Hello. I would like to try and help you in those critical clinical times when information is being presented and often we are possibly not paying attention. And then what I'd like to move into is some ways that you can use the model to help you explain to your patients more specifically about where their pain generator is. So you can also let them know that you're paying careful attention as soon as they come in the door. For example, if someone doesn't like to sit and they're standing in the waiting room, this is very, very common. They will fill out intake forms when they're standing. This should be a clinical clue. There's also, if they're also trying to press down on things, like for example the countertop, or if they're leaning up against the wall, if they have a cane or they have crutches, that sort of thing, of a more significant degree here, there's a load aspect associated with it. So in any event, let's say for example somebody walks in and they're standing, the standing patient. They walk in and they would rather speak to you while they're standing. Well, first off, the very first thing we should be thinking about is disc. Of course, you want to rule out pathology. That's always priority number one. But once you've determined that it's not pathological in origin, or you suspect highly it's not pathological in origin, what you want to do then is take them through their active range of motion. This is very simple. After taking detailed history, that sort of thing, you can listen to the mechanism of injury, or if there was one. Make sure you pay attention to that too, because you'll be able to explain the mechanism of injury with the model, and then you'll be able to demonstrate treatment strategies thereafter. So patient renders active range of motion, so very likely if you want to start with extension, you can get a basic understanding of whether the posterior aspects of the spine are the pain generator. So what I do is I divide, because it's very easy for the patients to understand this as well, I divide the spine into basically a front and a back, an anterior and a posterior. Is the pain generator likely on the anterior aspect, or is it on the posterior aspect? Okay. So very easy for patients to understand, front or back, right? Because for the most part, they don't even know that their discs are on the anterior side. So this is a very good learning experience as they go along. So for example, you take them through their active range of motion to extension, okay? Often with a discogenic problem, extension is, perhaps they have so much disc height loss that when they go into extension, their facets are going to be rubbing together. So you got to keep that in mind as well. But if it's a relatively young patient, young-ish, below 50, so they go into extension and you ask them, how does that feel? Well, if they tell you that it feels about the same or a little better, okay, you've got a direction for treatment here, okay? And you can give them some understanding about why you want to do that. So conversely, if they go into flexion and they only got 10 degrees, now you can, and they have leg pains associated with it, now you can grab the model. If you want at this point in time, is explain them specifically about what they just did and what just hurt them, or what you suspect just hurt them. Okay? Critical that they understand, that you understand, and you're paying attention to these very specific and subtle ranges of motion. Okay? So for that type of a patient, whatever your treatment strategy is, it may be you want to create flexion distraction or McKenzie protocol, that sort of thing. All really probably the ultimate goal and role as practitioners is for us to open up joint space with, whether it's disc height, vertebral end plate to vertebral end plate, or facet, right? IAP to SAP. So hopefully that will be helpful for you. Thank you.